So, natural history and pattern of failure. At presentation, the overwhelming majority of patients have locally, regionally advanced or disseminated cancer, irrespective of histological type. And the lack of serosal envelope and there is a rich submucosal lymphatic network of esophagus that leads to extensive local infiltration and lymph node involvement. So there is no serosal coverage in esophagus, and second thing, there is rich submucosal lymphatic network. Because of that, there is extensive local infiltration and lymph node involvement in case of CA esophagus. Evidence suggests that occult micrometastases are invariably present, and recurrence patterns confirm that distant failure is significant and universally fatal component of relapse. Bone marrow samples obtained during rib resection performed at an esophagectomy revealed disseminated tumor up to 90% of the patient sampled, and the lung, liver, bone are the most common site of distant disease. Depth of tumor invasion and lymph node involvement that predictive of the tumor dissemination. Most common site of mets is lung, liver, and bone. So median survival after esophagectomy alone for patients with localized disease is 15 to 18 months with a 5-year survival rate of 20% to 25%. Pattern of failure after esophagectomy suggests that both the location of tumor and histological type may influence the distribution of recurrence. The patients with cancer of the upper and middle third of the esophagus, which are predominantly squamous or carcinoma, locoregional recurrence predominates over distant recurrence. Locoregional recurrence predominates over distant recurrence, whereas in patients with lesion in the lower third, where adenocarcinoma are more frequently located, distant recurrence they are more common. Only a rare percentage of patients, less than 5%, develop a clinically evident recurrence at cervical site. Patterns of failure following multimodality therapy will be addressed later. Clinical presentation. Most noticeable symptom is dysphagia and weight loss. Dysphagia signifies locally advanced disease, distant metastasis, or both. Patients describe progressive dysphagia with an initial difficulty in swallowing solid and then liquid. Control of this single symptom impacts most of the patient's quality of life. Patients with squamous cell carcinoma of the esophagus more often have a history of tobacco, alcohol abuse, or both. And weight loss is seen in approximately 90% of the squamous cell carcinoma. Patients with adenocarcinoma, they tend to be Caucasian males from middle to upper socio-economical classes who have overweight with a symptomatic gastroesophageal reflux and have been treated with anti-reflux therapy. Approximately 20% of patients experience odynophagia, that is painful swallowing. Additional presenting symptoms include dull retrosternal pain, bone pain secondary to bone mets, and cough or hoarseness secondary to paratracheal nodal or recurrent laryngeal nerve involvement. So these types of symptoms suggest unresectable locally advanced disease or mets. Unusual presentations are pneumonia secondary to tracheoesophageal fistula or exsanguinating hemorrhage due to aortic invasion. So diagnostic study and pre-treatment staging tools. Patient with symptoms of dysphagia, they should undergo upper GI endoscopy and biopsy to establish diagnosis, identify biomarkers if appropriate, and perform mutational analysis. Biopsies or cytological brushing have diagnostic accuracy approximately 100%. Targeted biopsy can be enhanced and increase detection of neoplasm by use of advanced imaging techniques such as chromoendoscopy using vital dye, indigo carmine, leucoiodine solution, methylene blue, toluidine blue, or virtual chromoendoscopy. Autofluorescence imaging, narrow band imaging are endoscopic techniques that allow for detailed inspection of mucosa. Focused history taking should elicit information on predisposing factors such as esophageal cancer, tobacco use, alcohol use, symptomatic reflux, diagnosis of Barrett esophagus, and history of head and neck or thoracic malignancies. Prior surgery on stomach or colon may influence the choice of reconstructive conduit to restore alimentary continuity at the time of esophagectomy. So, finding history and physical examination that would prompt further diagnostic testing including hoarseness, cervical, supraclavicular lymphadenopathy, pleural effusion, or no onset bone pain. So, chest radiography and a liquid oral contrast examination of the esophagus stomach have been replaced by a CT scan, flexible endoscopy, and esophagogastroscopy allows for a precise evaluation of the extent of esophageal and gastric involvement and can precisely measure the distance of tumor from the incisors to appropriately categorize the tumor's location. Upper endoscopy also allows for the identification of the skip lesions or second primary as well as indicates the presence and extent of Barrett's esophagus. Bronchoscopy should be reserved for those patients with tumors of the middle and upper esophagus to rule out invasion of the membranous trachea and possible tracheoesophageal fistula. Although an endoscopic ultrasound or endobronchial ultrasound are now the procedure of choice to identify the unusual manifestations. Pre-treatment staging procedure establishes the depth of esophageal penetration, regional lymph node, and the presence of distant mats so that the patient can be guided about appropriate treatment. CT scan of the chest and abdomen are mandatory, and a single institution review of 201 CT scan of 99 patients undergoing staging of esophageal cancer indicated that imaging of pelvis did not contribute to added imaging information and may not need to be routinely performed. CT scans are highly accurate, 100% accuracy at a detection of liver or lung mats, suggesting peritoneal carcinomatosis. A site is omental infiltration and peritoneal tumor spreading. Accuracy of detecting aortic involvement and tracheobronchial invasion exceeds 90%. So CT scan is inaccurate in detecting T stage and N stage. So accuracy of endoscopic ultrasound in determining both the T and N stage is function of its ability to clearly delineate the multiple layers of the esophageal wall and its use in multiple criteria including shape, border, pattern, echogenicity and size, and to determine lymph node involvement. So EUS is superior to CT scan in both T and N staging. EUS is superior to CT scan in both T and N staging. Overall accuracy of T stage is approximately 85% and for N staging it is 75%. So what is the accuracy of EUS? 85% for T stage and 75% for N stage. And for determining lymph node involvement, its accuracy is 85 to 100% with the use of linear array EUS, with a channel that allows for passage of the needle to perform aspiration cytology. EUS is highly operator dependent and is limited in its ability to accurately define relatively superior lesions as they are T1 or T2, and this distinction is critical to allow for the use of minimal resection technique for T1 lesion and to avoid preoperative chemo and chemoradiotherapy for T1 T2 tumors. So mini probe high frequency 20 MHz sonographic catheters that can be passed through the working channel of the standard endoscope are now being used and provide improved accuracy. And a new generation of endoscope that are thin caliber may traverse almost all the obstructing lesion, allowing for EUS assessment. So the accuracy of EUS in assessing response to induction chemo is severely limited, and its use frequently leads to overstaging because of the fibrotic changes induced by treatment mimic residual tumor. Although recent data may indicate some utility of post-therapy US. So FDG PET scan is being widely applied in the management of esophageal cancer, both for staging and to assess response to preoperative treatment. And the accuracy of FDG PET scan in assessing regional lymph node falls somewhere between the low and high accuracy of CT scan and EUS respectively. And the detection of distant mets, FDG PET scan is superior to CT with sensitivity, specificity, accuracy in all ranging from 80 to 90%. So PET scan in combination with CT scan, that is PET CT fusion or hybrid PET FDG PET CT, further improves specificity and accuracy of non-invasive staging, and this leads to detection of the unsuspected metastatic disease in 15% of the patient, which leads to alteration of the intended treatment plan in at least 20% of the patient. The utility of PET to detect distant disease not identified by other imaging modality confirms the role of PET that is complementary to other staging procedures, although it should not supplant them. Utility of PET is as a biomarker and predictor of response to chemotherapy or chemoradiation is addressed later in this chapter. Minimal invasive surgical technique like laparoscopy and thoracoscopy, both they are being used for staging of both the local, regional and distant disease. Performing laparoscopy as a initial procedure at the time of planned and esophagectomy adds little in the way of time and cost to the procedure and allow for detection of the unsuspected distant mets, which spares the morbidity of laparotomy in 10 to 15% of the cases. So multiple studies suggest that the minimally invasive surgical approaches improves pre-treatment staging and has proved to be especially useful in GE junction tumors. A study comparing healthcare cost and efficacy of staging procedures including CT scan, EUS, FNA, PET and thoracoscopies or laparoscopic reported that CT scan plus EUS, FNA were the least expensive and offered the most quality adjusted life years on average than all other strategies. So PET scan plus EUS, FNA were marginally more effective but also more expensive. Thank you.